Alright, so in today's video we're going to be talking about, we're going to finally finish the arrhythmias, which is specifically non-sinus arrhythmias that we've been talking about for the past 3 videos. And we're going to finally finish the arrhythmia by talking about a disturbance in the rhythm whenever we have an accessory pathway in which we have a pathway that acts as a shortcut. When the SA node, since we have a drawing of the heart, the SA node, the AV node, then you have this pathway sending the action potential to the left atrium, and then to the AV node, and then to the bundle of His, and towards the right and the left bundle branch, and eventually to the Purkinje fibers. That's a revision. But normally, when the SA node sends its action potential, it will send it to the AV node, and the AV node will take this action potential and, as you know, will cause a conduction delay, physiological function, in which it will wait 0.1 millisecond in order for the ventricles to be allowed to fill with blood completely, while the atrium are depolarized and thus contracting, to push the blood downwards. So in a case of pre-excitation syndrome, where you have a non-specific syndrome, or Wolff-Parkinson-White syndrome, the most infamous example, in such a case of pre-excitation syndrome, we will have a case of accessory pathway, which is commonly between the atrium and the ventricle. And this accessory pathway, additional pathway, between the atrium and the ventricle, it acts as a shortcut. It acts as a shortcut. It allows the action potential of the wave of depolarization that's going inferiorlaterally, it allows it to bypass the AV node's conduction delay function. And thus, it can immediately go towards this accessory pathway between the right atrium and the right ventricle, for example, and cause depolarization of the right ventricle immediately. Because this accessory pathway, it doesn't have an AV node. There's nothing blocking on its way. It allows it to evade this AV node, and thus, without any hesitation, 100% speed, 90 miles per hour, it's able to go straight forward. It's able to go straight forward towards the ventricles. Like in such a case, it can depolarize the right ventricle immediately and cause early, premature depolarization. Hence the term pre-excitation syndrome. Pre as in early. Excitation means depolarization. We cause depolarization before we wait, before there's even delay. So in a case of pre-excitation syndrome, it can cause a disturbance in the rhythm, arrhythmia. How? Due to a congenital cause or a congenital development of an accessory pathway between the atrium and the ventricle. And they gave this name, this accessory pathway, they gave it a name. They call it the bundle of Kent. And this is specifically in people with Wolff-Parkinson-White disease. Wolff-Parkinson-White disease or syndrome. Now, regarding pre-excitation syndrome, now that we've learned about the pathophysiology, now let's revise the search pattern حقتنا. So if we remember the search pattern of our ECG from previous video, we started by assessing the heart rate. And then afterwards, we assess the intervals. The intervals of the PR interval, the QRS, as well as the QT interval. And then we check the axis. P wave, T wave, QRS. And then afterwards, we will assess the rhythm. We will assess the sinus rhythm by asking ourselves 5 questions. One of them is already the heart. And then number 5 would be assessing for what? Assessing for conduction block, right? Then we come to step number 6, in which we will assess pre-excitation syndrome. We will search for evidence of pre-excitation syndrome, and we will search for it in all of the leads. There is no specific lead in which we will search for pre-excitation syndrome specifically. We have to search all the 12 leads of an EKG. Some people use commonly lead 2, but to start with, you can scan all the leads because it's not specific. This syndrome, Wolff-Parkinson-White for instance, is not specific to a specific lead. So we must search in step number 6, pre-excitation syndrome, in all of the leads. And then in step number 7, as you know from previous video, we went to it immediately. Step number 7 was hypertrophy as well as atrial enlargement. So far, we have a total of 7 steps. Assess the heart rate, the interval, the axis, the rhythm, the conduction block, and then the hypertrophy and enlargement. And of course, in between step number 5 and 7, you have step number 6, which you must search for pre-excitation syndrome. So that's what we're going to be talking about in this video. And then in the next video, we will finally finish our EKG series by talking about MI, as well as certain disorders, cardiac and non-cardiac, that can have a specific change in the EKG. So in the next video, I'll draw it in the color red. In the next video, we'll be talking about assessing MI, which means ST changes, ST segment changes, as well as T wave changes, as well as Q wave changes. We'll talk about that in the next video. And then we'll have step number 9, which are others. We'll assess for things such as, we'll assess for other conditions that can cause changes in the EKG, like pulmonary embolism, like pericarditis, for example, like hyperkalemia, hypokalemia, and so forth. Step number 8 and 9 is according to the case. ممتاز? What I mean is according to the case, and usually nobody diagnoses MI based on an EKG unless they have the clinical context. So, and a lot of people, like for example, ER consultants, they will immediately know from an EKG whether it's MI or not. Because before they order the EKG, they talk to the patient. They took quick history from the patient, they did quick examination, so they have a suspicion of an MI. So the EKG is there to confirm your diagnosis, not make your diagnosis for you. ممتاز? So it's according to the case. If you have suspicion of MI, you will order the EKG and you look for it. If you have suspicion of pericarditis, burning chest pain radiating to the back, pericarditis, pulmonary embolism, hyperkalemia, and so forth. ممتاز? So step 8 and 9 is according to the case. But for the sake of our videos in the next one, we will be in order, number 8 and number 9. So it's a total of 9-step pattern. So now that we've summarized this, let's talk about the step number 6, pre-excitation syndrome. Now, we have 2 types of pre-excitation syndrome. They're not different from one another. It's a matter of exclusion. So, in pre-excitation syndrome, you have non-specific and you have a specific, which is Wolff-Parkinson-White syndrome with the bundle of Kent. You see, in Wolff-Parkinson-White syndrome, what we just discussed earlier about how accessory pathway, how it occurs, and what's the problem, we talked about it. So, in accessory pathway, as you know, this will cause a disturbance in rhythm, just simply because of one reason. The reason being, since this accessory pathway doesn't have any AV node to delay conduction, this will cause very early depolarization or premature ventricular activation. And thus, this will cause us a lot of problems. And this will give us specific changes on the EKG. One of the following changes you might see on an EKG is a short PR interval, and we'll talk about that shortly. A wide QRS, and we'll talk about that shortly. And the reason why there's a wide QRS is because there's a very specific wave that is exclusive, very exclusive to Wolff-Parkinson-White syndrome, which is the delta wave, okay? We'll talk about that shortly in this drawing. Alright, so that's Wolff-Parkinson-White syndrome, in which you have the presence of a bundle of Kent between the right atrium and the right ventricle, most common location. Then you have non-specific pre-excitation syndrome. This is basically non-specific. What that means is that you have a short PR interval. If you have a short PR interval, then you have nothing else. If you have a short PR interval and then you notice there's nothing else, there's no wide QRS, there's no delta wave, just a short PR interval which is less than 0.12 seconds, then you call this a non-specific pre-excitation syndrome. This is the most common form of the two. But what we are familiar with, what we are more concerned with, is Wolff-Parkinson-White syndrome. So you have 2 types. The only difference between the 2 is additional features. They're seen in Wolff-Parkinson-White disease. Now, you might have heard the term Wolff-Parkinson-White syndrome and Wolff-Parkinson-White disease. Very simply, in regarding definition, when people refer to Wolff-Parkinson-White syndrome, they refer to a confirmed diagnosis of Wolff-Parkinson-White on an EKG plus symptoms. So if a person is symptomatic with Wolff-Parkinson-White, shortness of breath, palpitation, they call it Wolff-Parkinson-White syndrome. Otherwise, they remove the term syndrome. You either call it Wolff-Parkinson-White or Wolff-Parkinson-White disease. If you want to be very touchy or very specific about the terms. But in general, people just refer to it as Wolff-Parkinson-White. You want to complete the term with symptoms, Wolff-Parkinson-White syndrome, with the EKG changes plus the symptoms, palpitation and shortness of breath, okay? Okay, now, what is the problem with pre-excitation syndrome? Actually, in most cases, people are asymptomatic in pre-excitation syndrome, okay? But the problem with pre-excitation syndrome isn't the fact that it may come with symptoms or not. The problem with pre-excitation syndrome, and specifically Wolff-Parkinson-White syndrome, that's what we're going to focus on. The problem with Wolff-Parkinson-White syndrome is that it predisposes. It predisposes, in about half of the majority of people, it predisposes to tachyarrhythmias. Yes, that's the problem with Wolff-Parkinson-White syndrome. It can predispose, it can lead to the development of tachyarrhythmias. So you might have Wolff-Parkinson-White syndrome plus a tachyarrhythmia. And the two most common tachyarrhythmias are supraventricular tachyarrhythmias, which are AVRT, atrioventricular reciprocating tachycardia, as well as atrial fibrillation. And the dangers of these two is that they can eventually develop into ventricular fibrillation. And we talked about the dangers of ventricular fibrillation. So that's the problem with pre-excitation syndrome, is that they can lead to development of a supraventricular tachyarrhythmia, AVRT, as well as atrial fibrillation. Mumtaz? Mumtaz. So, let's talk about the EKG changes of a pre-excitation syndrome. So let's start with Wolff-Parkinson-White. So, if you have an accessory pathway that is evading, that is basically having a shortcut, evading the AV node's function, and now we have a wave of depolarization coming from the SA node to this accessory pathway, letting it go straight forward immediately towards the right ventricle, depolarization premature without any delay from the AV node, well, it will give us the following EKG changes. One change is that if you notice in leg 2, there's a short PR interval, where if we compare, if we assess between the two, look at leg 2 and look at PE. PE is pre-excitation, Wolff-Parkinson-White. I want you to compare between the PR interval in this one and the PR interval in this one. If you notice, the PR interval here is normal, which is between 0.12 to 0.20 seconds. But if it's less than 0.12 seconds, it's shortened PR interval, then this is a change that is seen in the EKG with Wolff-Parkinson-White. Why is it shortened? Because this PR interval, this represents the conduction delay of the AV node. But if I have no action potential going towards the AV node and going towards the accessory pathway, immediately going towards the right ventricle, then naturally the PR interval will be shortened, right? So we will have a shortened PR interval. And since this wave of depolarization, since it's going to depolarize the right ventricle early, it will lead to a widening of the QRS complex as compared to this. This is a narrow QRS complex, this is a widened QRS complex. And the reason we have a widened QRS complex is because you see this delta wave. This delta wave is what you see here. We take a zoom in, this is the delta wave. This is the delta wave, which is defined as the initial upstroke. So if you see an upstroke, compare this one to this one. Instead of going immediately vertical, if you see an upstroke in the initial part of the QRS, then this is termed as the delta wave. And this delta wave contributes as to the reason why we have a wide QRS complex. Mumtaz? So this is a very specific finding in Wolff-Parkinson-White syndrome, in which you have a shortened PR interval followed by the development of a delta wave, in which an initial rapid upstroke, as compared to this one, this initial rapid upstroke, instead of going vertically, it will go like this. This will lead to the development of also a widened QRS complex. So you must look for these findings: a shortened PR interval, a delta wave, and a widened QRS complex. 3 of these changes, scan for them in all of the leads. Look at them in all of the leads. Mumtaz? Mumtaz. Now, why is there a widened QRS complex? We already talked about why there's a shortened PR interval. But why is there a widened QRS complex? Well, simply put, here's the thing. When we have a wave of depolarization, Mumtaz, when we have a wave of depolarization going towards this route, and it will also go towards this route. Mind you, not every wave of depolarization will go towards the accessory pathway. They will go towards both direction, Mumtaz, both direction. They'll go towards the AV node, and they also will go towards the conducting pathway, the accessory pathway, okay? Now here's the thing. When it goes towards the AV node, it will depolarize the left ventricle as normal, okay? And the left ventricle, as you know, it's much bigger than the right ventricle. So when there's depolarization, it will be much more in left ventricle as compared to the right. So we'll have normal depolarization of the left ventricle from the AV node. And thus, we will have what we call here, a QRS. Alright, we'll have a QRS, Mumtaz. So that's what we'll have here. We'll have a normal QRS initially. So we'll have this as usual, Mumtaz, due to left ventricular depolarization. Okay? So we'll have an R wave as normal, and we have an S wave. However, this is the normal pathway. However, because we have a wave of depolarization that's not just going through the AV node, it's also going through the accessory pathway, well, what does that mean? Well, you'll have a QRS that basically will be widened, not because of left ventricular depolarization. No, this one is normal, Mumtaz, this one is normal. But at the same time, when the wave of depolarization also reaches the accessory pathway, it will cause premature activation or premature depolarization of the right ventricle. And premature depolarization of the right ventricle will give us the development of this delta wave specifically. So instead of this going upwards, instead of basically the R wave or the Q wave, instead of it going upwards immediately, it will cause an initial upstroke. And since you know premature activation of the right ventricle occurring very early, it will give us an upward deflection gradually, Mumtaz, a little bit gradually. At the same time, while this delta wave is developed, the remaining left ventricular is being depolarized. So it will continue. So if I were to just draw it more specifically, this delta wave right here, this represents right ventricular depolarization early. And at the same time this is occurring, at the same time, while there's premature activation of the right ventricle, you have the remaining left ventricular depolarization coming from the AV node. And this will continue joining along with the R and the S wave. So when you have a depolarization of the right ventricle and a depolarization of the left ventricle, both of them coming together, especially if the right ventricle occurring very early, well, it will give you the picture of this. So you have right ventricular depolarization contributing to the delta wave, and then followed by additional wave of depolarization coming from the left ventricle from the AV node, the remaining part. And this will contribute, or specifically the delta wave will specifically contribute to a widened QRS complex. Not like normally. Not like normally in normal cases you will have, in a normal case, you will have a wave of depolarization only coming from the AV node, and from the AV node it will come down and it will depolarize both the right and the left ventricle equally in terms of timing, equally. But in the case of Wolff-Parkinson-White syndrome, we will depolarize the right ventricle first, very early, and then shortly afterwards we will also depolarize the left ventricle. So it will give us a widened QRS complex thanks to the contribution of this delta wave, which represents specifically depolarization, early depolarization of the right ventricle. Mumtaz? Mumtaz. So that's pretty much it for Wolff-Parkinson-White syndrome. Now let's talk about the issue of Wolff-Parkinson-White syndrome. You might find Wolff-Parkinson-White syndrome along with a tachyarrhythmia. So they call it, for example, atrial fibrillation with WPW, AVRT or supraventricular tachycardia with WPW, meaning this tachyarrhythmia, supraventricular, both of these, they come from the WPW rather than on their own. Mumtaz? So, we start with atrial fibrillation. You remember atrial fibrillation from previous video? It can occur on its own from multiple atrial foci, or it can come from Wolff-Parkinson-White syndrome. So atrial fibrillation either comes from multiple atrial foci, or it can come from Wolff-Parkinson-White syndrome. ممتاز. Because of this accessory pathway, predisposing it to tachyarrhythmias, supraventricular. And it can lead to ventricular fibrillation. So that's one tachyarrhythmia, easy, right? Very dangerous. But now let's talk about something new. Whatever you took in atrial fibrillation is the same from previous videos. But let's talk about AVRT. This is a little bit new. AVRT, atrioventricular reciprocating tachycardia. Now, what is AVRT? Well, AVRT is simply put, it is because of this accessory pathway, it will give us a unique tachycardia. Now, to make it easier, AVRT, which is AV nodal, or let's say, not AV nodal, sorry, it is atrioventricular, there's no node involved, atrioventricular reciprocating tachycardia. From the name, atrioventricular reciprocating tachycardia, from the name, there is a tachycardia because we have an electrical current. There's an electrical current that is reciprocating between the atrium and the ventricle. There's no AV node involved. We just have a wave of depolarization that is reciprocating, meaning it goes from the atrium to the ventricle, back to the atrium. And it gives us, thus, two subtypes according to the direction. Are we talking about a wave of depolarization, which is between the atrium and the ventricle? Are we talking about a wave of depolarization that is reciprocating between the atrium and the ventricle, going towards a direction towards the front? Or are we talking about a wave of depolarization that's reciprocating between the atrium and the ventricle, going backwards? A wave of depolarization that's going backwards instead of going forward. Forward and backward to where exactly? Forward and backward towards the AV node. So let's make it more clear in this drawing. So, to summarize, we have another supraventricular tachyarrhythmia coming from Wolff-Parkinson-White syndrome. It's called atrioventricular, between the atrium and the ventricle, atrioventricular reciprocating tachycardia, okay? And we have two subtypes according to the direction of the wave of depolarization that is going towards the AV node, from the front to the ventricle to the atrium, or al-aks, from the atrium, from the accessory pathway, from the ventricle to the AV node and back. We'll make it clear in the drawing shortly. So we have two subtypes. We have two subtypes of an AVRT. We have orthodromic, which looks exactly the same as AVNRT in changes. It looks literally the same. Orthodromic AVRT. And we have another subtype. It's called antidromic, which is a wide complex tachycardia. Okay? So let's talk about both of these subtypes and what do we mean by AVRT, okay? So simply put, when we have a Wolff-Parkinson-White syndrome, when we have a conduction or an accessory pathway, sometimes the action potential, sometimes it comes to either pathway. It can come to the accessory pathway, and it can also come to the AV node. This wave of depolarization from the SA node, it can come to either pathway way too early, okay? So you might have a premature atrial beat. You might have an action potential that comes towards both of these pathways way too early during repolarization. So, as you know from previous video, when we have a wave of depolarization coming towards an electrical conducting system, like for example, we talked about the bundle branch, when we have an early action potential coming towards, for example, the conduction system or the accessory pathway way too early while it's still repolarizing, or it comes towards the AV node way too early while it's still repolarizing, this can lead to what is known as the refractory period. There is a refractory period in which, while we're in repolarization, the accessory pathway or the AV node, they don't accept an action potential. So when we have an action potential that's sent very early, the action potential, it will be deflected, it will be rejected by either the conduction or the accessory pathway or by the AV node, because both of these pathways are in the refractory period during repolarization. That means you will not give me an action potential until I finish my repolarization. If I'm not fully repolarized, your action potential will go somewhere else. Okay? So this happens This happens because we have an early action potential, a premature. So what happens? What happens is very simply, okay? If we have an action potential or a wave of depolarization that is coming from the SA node, okay? And it goes to the AV node. And the AV node told it, no, I reject this, I'm in my refractory period. Then this wave of depolarization, it will come towards instead the accessory pathway. So it will not come towards the AV node, it will come towards the accessory pathway, okay? And then what happens? It will go downwards. It will go downwards and it will depolarize the right ventricle, okay? And then eventually, since it comes towards this pathway, eventually this wave of depolarization, it will come towards the AV node. Because here's the thing, by the time this wave of depolarization, once it reaches down, the AV node at the same time is no longer refractory. It's no longer rejecting. It is accepting of this wave of depolarization. So, at the start, when there's a premature action potential, it will go away from the AV node because the AV node rejected it. But once it comes down the accessory pathway instead, once it comes down, now suddenly the AV node is accepting of it. So now this wave of depolarization, it will go, what they call this, it will go retrograde, okay? It will go the opposite way. Mumtaz, it will go literally retrograde. Mumtaz? And here's the thing, when it goes retrograde, and it goes towards the AV node, and it goes towards the AV node, now guess what? Once it finishes towards the AV node, it will come back to the same issue. We will come back to the same start from before. So, we started first running away from the AV node. Then we came towards the accessory pathway. Then we came down. While we came down, at the same time, the AV node was accepting. And then what happens, now this wave of depolarization, it will come towards the AV node from backwards, retrograde. And when it comes towards it retrograde, now we come towards the same starting area. We now go away from it, we now come towards the conduction pathway, and we form a loop. We form a reciprocating loop in which we have a wave of depolarization that is reciprocating between the right atrium and the right ventricle, going backwards towards the AV node, going backwards. So what is the EKG change that's going to occur here? What will the EKG looks like? All right, as a result of refractory period of the AV node, what will the EKG look like? Well, very simply. Do you see this wave of depolarization? This wave of depolarization is going to come towards the AV node, all right? And when it comes towards the AV node, since it's going backwards, this is an unusual direction. That means this wave of depolarization is going to cause depolarization of the ventricles from an unusual direction, from the opposite direction. That means the wave of depolarization, when we look at it from leg 2's perspective, this wave of depolarization is going to depolarize the left and the right ventricle, as well as the AV node, away from the leg 2. And as you know, when we have a wave of depolarization that's going away from leg 2, and it's going to cause a depolarization of the left ventricle as well as the AV node at an unnatural state, at an unnatural direction, at such an inefficient pathway, anything besides this pathway towards this pathway, it will lead to the development of a wide complex tachycardia. So, we have a wide complex tachycardia as a result of a wave of depolarization. Instead of it coming from the AV node and depolarizing the left and the right ventricle the normal way, the efficient way, the wave of depolarization, in the case of this one, it will depolarize it the opposite way, the inefficient way, away from leg 2 and towards retrograde, backwards towards the AV node, and form a reciprocating loop. So this will give us what? This will give us AVRT, atrioventricular reciprocating tachycardia, antidromic part. Antidromic, the opposite direction, similar to this. Mumtaz, similar to this. And this gives us a wide complex tachycardia. So you put this in your differential diagnosis. One of the causes of a wide complex could be an AVRT
antidromic type. Okay? Okay. And this will be seen along with a WPW change. So you might have Wolff-Parkinson-White plus AVRT antidromic, okay, on an EKG. So that's white complex tachycardia antidromic. And what I just mentioned now, the same concept. The same concept applies to the other subtype of AVRT, which is orthodromic, which is the brother of AVNRT. Remember when we talked about AVNRT, atrioventricular nodal reentrant, laser reciprocant, reentrant tachycardia? Remember when we talked about this one? It is the same change, the same EKG finding. So AVNRT and AVRT orthodromic type, they both appear the same. They are brothers, they are twins. They both appear the same, meaning you have a narrow QRS complex and no T wave and tachycardia. Mumtaz? But the origin here is different. In AVNRT, the reason for AVNRT is because we had a reentrant rhythm. We had a reentrant rhythm in the AV node. But here we have a reciprocating rhythm that is occurring between the atrium and the ventricle, which has nothing to do with a loop circuit within the AV node. So the origin is different, but the end result is the same. Okay? And how does this occur? The same concept that we just applied to antidromic. Instead of the AV node being refractory, we have an early action potential, very premature, that's going towards where? Towards the accessory pathway. Now the opposite. Now it's the accessory pathway that is refractory. And if it's refractory, now it will go where? It will go towards the AV node. And if it goes to AV node, it will go anterograde, the forward, the normal pathway. It will go anterograde towards the AV node. And thus, it will depolarize the left ventricle as usual. So you will have a narrow QRS complex, not a widened QRS complex. It will depolarize it as normally. But here's the thing. Eventually, this wave of depolarization, once it depolarizes the left ventricle, eventually it will come back up towards the accessory pathway. You know, this open pathway is going to come back towards it. And it's going to come back towards this accessory pathway, come up, and now it will reset. Now it will form a reciprocating loop in which we started with a wave of depolarization going away from the conducting pathway or from the accessory pathway because of refractory period. It went away from it, it went anterograde towards the AV node that's accepting of it, and then once it comes down, it will depolarize the left ventricle normally. But once it comes down, at the same time, the accessory pathway is now accepting. It's no longer in its refractory period. So it will come down, and then it will come up, it will go up the accessory pathway, and then it will loop again and again and again. So there will be a reciprocating circuit, an electrical current, a wave of depolarization that is reciprocating between the atrium and the ventricle, anterograde towards the AV node. And thus, it will give us the appearance of a narrow QRS complex with no P wave, because there's no depolarization. Mumtaz, there's not going to be a depolarization of the right and the left atrium the normal way. If there is a depolarization of the atrium, it is hidden. You will not see it. It is hidden, or in some cases, it will depolarize it the opposite way towards the right atrium, and you might have a retrograde P wave, as you remember from previous video. But normally, in such a case, you will not find any P wave that's going to depolarize it the normal way. It will be hidden, and instead you might just see a narrow QRS complex that is tachycardic and regular. The same image finding of an AV in RT. But the origin is different. Mumtaz? Mumtaz. So, we now have finished Wolff-Parkinson-White syndrome. We talked about step number 6, where we researched for pre-excitation syndrome in all of the legs. There's non-specific in Wolff-Parkinson-White. And Wolff-Parkinson-White, due to a congenital development of bundle of Kent, it will give us the following EKG findings, such as a shortened PR interval and a widened QRS due to the presence of a delta wave, which is an initial rapid upstroke, okay, of the R wave. And then, the most important part of why we should know about pre-excitation syndrome is that the majority of them are asymptomatic. but we should know about it is that because this pre-excitation syndrome, which will causing a disturbance in the rhythm, so an accessory pathway, we should know about it because it can lead to the development of supraventricular tachyarrhythmias. Mumtaz. And the most common ones, atrial fibrillation, which can lead to ventricular fibrillation, as well as AVRT, atrioventricular reciprocating tachycardia. And we have two types, according to the direction of the wave of depolarization that is reciprocating between the right atrium and the left atrium. Because we have an early premature action potential, whichever one will be refractory will decide whether we will have an orthodromic AV-NRT brother, or we'll have an antidromic, which is a wide complex tachycardia that is going retrograde, opposite way towards the AV node, while the orthodromic is going anterograde, forward towards the AV node. Mumtaz. So that's the two subtypes of AVRT. Okay? Okay. We have now finished Wolff-Parkinson-White syndrome, and now in the next two videos will be the final videos for our EKG series.